Good morning. My name is Kevin Ford. I am a student in the methodology class. This is my 45-minute video. My 45-minute video will be on basic airway management. I'm a paramedic supervisor. I've been a paramedic for a long number of years. I was an instructor for a long number of years and let it lapse. So now I'm redoing my methodology so I can reobtain my instructors. So with that said, we're going to dive into basic airway management. I've got some objectives I'd like to cover. So with that being said, objectives. I gotta put my old man glasses on because I'm old. I know this is a video and it's not really interactive, but if you have questions, comments, please feel free to send me an email. I'll answer them to the best of my ability. Thank you. All right. First of all, we need to define the needs, okay? Who, when, how much, and what airway management do they need? All that's based upon your assessments, correct? Devices and flow rates. What do we mean by devices and flow rates? We have a nasal cannula. It sets anywhere from a half a liter up to, I don't like to take them above 6. 4 is quite a bit. You get 6 and above. They do make a high flow nasal cannula that can flow. I've seen them with an AirGen flowing 20 some liters a minute. Nothing that we have in 911 will meet that demand. You go from that to a neb mask for an albuterol inhaler, correct? I'm not going to classify that as in our basic airway management, so I'm going to skip to the adult non-rebreather. The adult non-rebreather are for your hypoxic patients that usually their sats are anywhere from 60 to 85, 90, depending on the provider. Some providers like to put the non-rebreather on at 90, some do it at 92, but our monitors will only say less than 50 if that's what the O2 sat is. With the non-rebreathers, we like to set them at a flow rate of obviously 6 to 15, depending on the need of that patient. So, airway adjuncts. What is an airway adjunct, right? It's a device that we're going to use to put in either the nose or the mouth of that patient to help secure that airway. Not really secure it, but open it up. Hold it open for us. We have the OPA, which is the oral pharyngeal airway, right? We have the NPA, which is the nasopharyngeal airway. Sometimes it will be referred to as a trumpet because it looks kind of like a trumpet. The number one thing that people overlook, suction. Suction is so important. I don't care what adjunct, what device you're using, we need to keep that airway as clear as possible. And we have the BIADs. These are the Air Q3s. A lot of agencies use the Air Q3 and iGel or a King. We just use an Air Q3. And of course, the basic of the basics, right? A bag valve mask. The basic of the basic. So, along with that, we need to go over, right, for our objectives. How do we measure each device, each adjunct, if you will, and how do we place it? Everybody can look at a textbook, everybody can look at pictures, but I can promise you from experience that placing an adjunct or an airway is a different animal on a human than it ever will be on a mannequin. This mannequin is an airway mannequin, and I have tried to get the NPA in it, and I've been very unsuccessful in that endeavor. So we'll try again. So questions about the objectives. So by the time we get finished, you should know what each adjunct is, how it works, how to measure for them, how to place them. And then once all that's done, you continue your assessments and your reassessments to see if your intervention is working, is it helping, is it hurting? We don't know until we do it. The reason behind the airway management, the basic airway management, if you will, is why. Why is that? Because we can do a lot of things. Think about CPR, right? We can compress the heart. We can we can make it pump, right? But with that being said, can we circulate blood? Absolutely. But if we don't oxygenate that blood, what are we circulating? Deoxygenated blood. Oh, hold on a second. I apologize. Okay. So, with that being said, by the time we get done, we're going to know when and how to suction, when and how to place and measure OPAs, MPAs, BIADs, and everybody's favorite, the adult bag valve mask. People see these and they automatically assume that we know everything about them and we know how to use them. That is not the case. If you notice, this is a small bag, right? Our agency and some other agencies have switched to the 500 bags instead of the big adult bags. Why? Because we were finding that we were pushing too much air and causing what? What happens when the air exits the airway tract and goes into the GI tract? Distension, vomitus. We learned that we were using a lot of suction, that we had a lot of unprotected, unnecessary airway problems. So we've switched. Some of our first responders, they were not happy with these at first, but now they're learning to enjoy them. So if we have a patient and you walk in, you should be able to tell by looking at them. You know, you can tell if they're in distress, if there's airway management issues, if you will. Are they tripoded up? Are they diaphoretic? Are they struggling to breathe? How much accessory muscle are we using? It's more pronounced in pediatrics than it is adults, because pediatrics use accessory muscles any more profoundly than we do. So when you see a pediatric using a lot of work and effort to breathe, they're going to tire out faster than some of your adults do. So you're going to have to be ready to assist with that airway. Adults will get tired too. The older geriatric population, if you will, they're tired. So don't be surprised if you have to help them or assist them with their ventilations. So after we do all that, right, we constantly reassess that patient, always. I'm sorry if I talk with my hands, it's just what I do. I apologize. So with that being said, we're going to talk about bag valve mask, which is the basic of the basics, right? Everybody claims that they know how to use a bag valve mask. Do we? Do we know how to properly use it? First of all, we have to have the right size mask on it, right? What is the volume? Okay, they make some that have these little flashing lights on them that will blink every 6 seconds. Why? It's a reminder to squeeze that bag. And when we do that, how hard are we squeezing that bag? Are we crushing that bag every time we squeeze it? No. All we want to do is get the chest to rise and fall. That is all. Anything else, you're overinflating the lungs, you're causing distension. You could basically, depending on the patient, you could cause a lot of trauma in there. You could cause a pneumo. Not trying to, but you can. You know, so we want to be careful. We just want that chest to rise and fall. That's all we want. We don't want to push. We don't want to do any of that craziness, right? Why is that so important? Because we want to do no harm, correct? So we go in and they're already in distress. The last thing we want to do is create more of an issue and have to treat more issues that we've created by trying to help them. So you could come in, your patient could be supine, your patient could be prone, your patient could be tripoded. Some of them are in a recliner. A lot of your CHFers will sit in a recliner because if they lay back all the way, the fluid in their lungs comes from the bases up and it feels like they're drowning. So they're going to sit up as much as possible. They'll sleep in those recliners. They'll live in those recliners. So it's very important that we know and understand why and the how and continue that reassessment. Do we walk in every patient and say, oh, I'm going to have to bag them? No. Do we go in every single patient and say, oh, you need an MPA or an OPA? No, we don't. Because a lot of patients have patent airways that they can maintain. When we're using the adjuncts and the biads, we are doing something to help them, if you will, maintain that patent airway. And these are somewhat invasive, but not too invasive, if you will, until you get to this. So the important thing is that we know the sizes, when to use them, how to use them properly, and once they're in place, what signs do we need to look for? What are our issues? Okay, what could be our issues coming up? Right? So there's indications for everything. There's contraindications for everything. Correct? You have a patient needs BLS management. So OPAs, right? Everybody's like, oh, it's the J shape. Yeah, it is. Okay. And for years, the AHA said this was an acceptable means of airway management in a cardiac arrest until you got ROSC. Then you could pull this and put an ET tube in. Over time, we've switched away from that. MPAs, right? Commonly used. I don't know about you guys, but a lot of our people use them for overdoses. They'll pop these in, start bagging them up, get that side up, give them a little bit of Narcan to offset the opioid to get that respiratory drive back up, if you will, which gets the SAT back up. So everything is intertwined. Go back to this. Indications, right? Indications. Unresponsive. Apneic. Cardiac arrest or not. Unresponsive. Apneic. With these, though, we have to make sure that there's a couple things. They don't have an intact gag reflex. If you start to place this and the patient starts gagging, it comes out. Don't even attempt it anymore. Okay? Intact gag is one. Also, have they ingested any caustic substances, acids? Because if they have, these are plastic. These are going to melt. Okay? They could very possibly adhere to the inside of the patient's airway. And that's not what we want, because then what are we doing? We are creating more harm than we were trying to help with. How do we measure for these? Does anybody know? Anybody? Justin, how do we measure for an OPA? Yes, there's someone in here with me.
From the lobe of the ear to the horn of the mouth.
Bingo, just like that. How do we place them? So what's important about these is I've seen it, I've heard it, I've watched it on calls and classes and training. These airways go in backwards, right? You can go sideways, if you will. And once it goes in and you rotate it back down to where it's supposed to be. You don't just plop it in there. A lot of people will tell you to put it in backwards and start rotating it down. When you get down, it should be turned towards the patient's body, not the head. MPAs, nasals, right? Remember, I said this mannequin was extremely difficult. I'm not sure what's going on with his nose. There's like hard plastic things in there. This is an airway mannequin. You would think it would be much easier to put a trumpet in. But I have struggled probably 30 minutes before I started to make this video. Okay. We measure these. Justin, how do we measure these?
Corner of the nose to the ear.
From the nose to the ear.
The
Would you look at that?
base of the nerve.
Yeah. Would you look at that? That's supposed to be the right size. But I have put lube on it. I have put gel on it. And this mannequin's nose does not want it. He cannot take it. So basically, I will not be able to show you how to place this. I apologize. This is an airway mannequin, so you would think you'd be able to do that. Crazy, right? So, first thing we're going to do, we're going to select the correct size. Okay, what are your indications and your contraindications for these? We went over the OPAs, right? Gag, some form of ingestion that may be caustic. Okay, those are out. Well, guess what? If those are out, so are these. Okay, but the trumpets or the MPAs, right? You lube them up. You take a little bit of lube, airway lube. You just put a little bit on there. What you don't want to do is coat it, right? What do you have on? Gloves. So when you coat this thing in lube, guess what's all over your hands now? The lube, and you won't be able to hold on to anything. The bag, the trumpet, anything. It's all going to slide around. Lube it up. Justin, bevel towards the nose or away from the nose?
Towards the septum.
Ah, see? Smart. Why? Because it's part of our contraindication, correct? We do not put these in for the patient who has suspected head trauma. Why? Because 2,000 years ago, this is what I was taught a long time ago, was that what? Somebody put one of these in, and because of the trauma to the head, it magically turned and went to the brain. So for eons, we don't teach to insert these if we suspect head trauma, right? Bevel to the nair, lube it, we put it in, and you'll feel it slide all the way down, and it'll sit at the base of the nair. So everybody, and I say this because I've seen it on numerous occasions, ALS providers, we get so in tune of they're clenched, I can't get a tube in. And for those agencies who do not use drug-assisted intubation to paralyze or relax that patient, they get flustered. But they forget something as simple as this. If you can put two of them in, and just bag that patient up to get their sats up. Okay? So we've covered that. Let's cover this suction, right? Everybody knows suction. If they're unresponsive and there's no trauma, no spinal issues, roll that patient, suction out. What you don't want is all that emesis staying in there, right? You're going to try to bag. You're going to force all that down into where? The lungs. So then we're going to have issues not trying to ventilate that patient, because you can move that air down in that airway, but you can't oxygenate them. So that could be a massive problem. We wanted to avoid that. So if the patient doesn't have trauma, let's roll them, right? Let's let it drain out, take a suction, suck it all out of there. We have gotten away from the Yankauers. We use a Decanto now because they're so big. We can get chunks. instead of just that little bit. So these are really hard to clog. You can, but they're a lot harder than the Yankauer's water. So that being said, we've covered what? Measurement and placement, indications and contraindications. Measurement and placement, all right, and indications and contraindications. Our friend is called a suction, correct? And the biads. We haven't really covered them much, but we will. Basically the same indications, right? Do they have an intact gag? Yeah, this is out. Caustic ingestion, this is out, right? We don't want to use them. Remember, do no harm. Everybody's favorite thing in the whole wide world, a bag valve mask. How many times have you got on a call and your first responders or no trucker going? I mean, they're crushing, right? No rhyme, reason, no, because adrenaline's up. They're all excited, you know. So we need to be that voice of reason. Good deep breath, slow down. You just want to get the chest to rise and fall. You squeeze easy. No barotrauma. And we see this a lot. They'll come in, they'll take that bag valve mask and they push it down, right? They're like, I'm like, are you getting good compliance? Well, no, because we're doing it incorrectly. You don't push this down on the patient. You place it. You remember the CE, right? Make that C and that E. You're going to pull that patient's airway up into that mask. And we're just going to squeeze just enough to get the chest to rise and fall. A lot of you aren't going to like this, but the correct way to use these is a two-person technique, not a one-person. One person holds the mask down on the face, and they pull that jaw up into the mask, and they just squeeze it. Because if you're coming up and you're doing this, you see what the airway does? Is it open? You're pushing it down, right? This is the most common thing that we see. This, the CE, pull that airway open, right? Just enough to get the chest to rise and fall. We can use this all by itself. You're getting really good compliance, you're oxygenating, you're ventilating. This is fantastic. It's great, right? If we're not, we're going to switch to an adjunct. Do they have a gag? Yes. We're going to switch to the MPA then. If they don't have a gag, hello, and they've not ingested any caustic substances, we're going to select the right size, right? We're going to say, man, that looks about right there. Remember, you can put this in. Look, I'm doing it. You can. Some people go like all the way backwards. I like to go from the side at an angle, and when I go down, I just work it right on down straight. And what it's doing is it's pushing that tongue up off the back, right? It's pushing it up. It's holding that tongue up and out of the way. Should give you better compliance. You still do that, the C and the E, right? You want to still pull that airway open and squeeze just enough to get it to rise and fall. That's all we're looking for. We're not looking for, like I said, how many times have you walked in and you see them take that back, crush it, right? They're crushing it. Adults have tidal volume of around 400 to 600, depending on the height of the patient, total lung capacity. So when you have the big bags that are 1,000 or 1,250, and you're squeezing that thing, you're doubling the capacity of the lung. What's going to happen? If you don't pop it, causing a pneumo, you're going to put another 600 ml of air into the GI system, which is going to cause you to see really everything they've ate in the last 3 to 4 hours. Not only are you going to get it, but it's going to go into that airway. We don't want it to go into that airway. We want to protect it. at all costs. It's golden to us. That airway is one of a kind, right? We want to keep it, we want to save it, we want to savor it. Talk about these patients that present with chest pain or having a hard time breathing. Their SATs are 90, 93, 94 even. We can use this beautiful nasal cannula and set that flow rate at about 2, right? We can put this on the patient. We can put it on the patient, and I think every EMT should have to do this backwards in order to pass the state. I'm just saying. So we can put that on. We can assess, right? Is that SAT going up? Is the SAT coming down? Difference between this and the end-tidal is what? The end-tidal, we're going to the monitor, it's going to give us a better tracing as to what, are they air trapping? Are they trapping air in? Or are they exhaling all of their air? Are they trapping any? That's going to help us there a lot. But remember, the nasal cannula, it may just be for your comfort. Patient SAT may be 98%, but it's, I can't breathe, I can't breathe, I can't breathe, I can't breathe. If you put this on at a leader, it's going to make them comfortable. With that being said, are you giving a lot of oxygen? No, not particularly, right? It's more for comfort. And your chest pain patients, you for sure will want to get them on something, right? They're having chest pain, STEMI or not, right? If it's a cardiac in nature event, somewhere the heart is going, I'm not getting enough what? Oxygen. So, through the blood flow. So a little bit of oxygen is going to help them, no matter what. Everybody starts screaming, you know, I'm going to tell my age because way back when we had Venturi masks. Every truck had them because everybody was so concerned about knocking out the hypoxic drive, right? Oh, these COPDers, these CHFers, we're going to knock out the hypoxic drive, and oh my God, we have to be careful how much oxygen we give them. We can't give them 100% on a non-rebreather. You're going to knock out their hypoxic drive. I've been doing this a long time. And I have never knocked out a hypoxic drive with oxygen. I have with medication, purposefully, but never with oxygen. Non-rebreathers, right? We touched on the neb mask briefly, but I said we're not going to use those. Why? Because I think that's more of getting into airway management for specific causes, right? Non-rebreathers. They assemble quickly, right? You got the mask, the reservoir bag, and the tubing that goes to your O2 tank. What's the flow rate and why? We talked about the flow rate for that nasal, right? We said anywhere from a half a liter to 6 liters. Okay, we're going to take this. I like to start these no less than 8 to 10 and run them to 15 as needed. But before we do that, you know, we hook it all up. We're not going to just put this on the patient's face, right? You want that reservoir bag full. There's a little valve on the inside. I've seen some people just wait. I've seen some people take their finger over the valve and the bag will fill up. Then we put it on the patient. What you don't want to do if you're going to move this patient, let's say we filled up the reservoir, all that good stuff, right? It's hooked to oxygen, and we've got that on the patient, and their SATs are improving, and everything's good. And then we're going to move them. So we're going to pop this off of one tank. If you pop this off, take this off. Because why? What are they breathing in now? Their exhaled air. Take it off. Is it bad? I think so. A lot of folks will tell you no. I think it's bad. I do not recommend it. You walk in a hospital with a patient on a non-rebreather that you've unhooked to move in, and the ED staff is probably going to have a stroke if they haven't already. So, don't recommend. Do not recommend. So we've talked about the non-rebreather. We've talked about the nasal. We've talked about the adjuncts. We've talked about suctioning. Let's talk about this biad a minute. What does that do? Does that really give us a secure airway? No, it does not. It doesn't properly seal off. This is the way this is designed. The heat of the body is designed to make this stick. If you have a hypothermic patient, a drowning patient, these are going to move. They're designed to sit against the airway, right, and sit there. Well, if the body's cold and wet, that's not going to seal up. Okay. A lot of people like them. A lot of people don't. They size them by height. Okay. These are basically a one and done deal. You can pop them in there and they're great, right? You're like, oh, I've seen them put them in. I like to grab that jaw and pull it up. Of course, you want to lube it. I probably need to lube that one because it doesn't want to go in that dry mannequin. We don't really use the lube on the mannequins. We get a little bit of hand sanitizer. So, make it a little bit slippery. We're going to put it in, right? Just going to slide right on down against the airway. And it's it. That's it. Of course, we're going to take our end-tidal capnography in our ears because we want to listen, right? We want to make sure that that's in the correct location. Just enough to make the chest rise. Biads. What we're going to talk more about is this basic airway management without the biad. You can do this basic airway management without these, right? So the NPAs, the OPAs, once you get them in, you just bag, right? You can take that bag of out mask. It just shows you when to go, whether it's an MPA or an OPA, and ventilate. All right, that's what it's there for. It's designed to let the air pass through it, in and out. So, why is it so important? Because that airway is golden. You've only got that one airway. If you lose the airway, you have to resort to things that you don't want to do. They're high risk, high fidelity, low frequency skills. We try to avoid those. But a lot of your problems, these patients can be solved by BLS airway management. Everybody said, oh, and for the medics and the advanced and the higher certified providers, they're going to jump straight to a tube. It's the golden standard. Yes, I will not disagree that it's the golden standard. But do we need it all the time? No, we don't. We forget the BLS side of it. So the BLS is very important for you, for your patient, for the hospitals. The less invasive you can do to maintain it and is maintaining well without a problem, I recommend it. Because you start placing tubes, and adjuncts are simple. When you start putting the biads in, there's some patients that they can never wean off of a vent because either you put that biad in, and then, I'm not saying don't do it if they don't need it. If they need it, by all means do it. But there are some patients that they get tubed and then they can never come off the vent. But that's neither here nor there. So let's talk about this again. Let's make sure our objectives were met. Okay? who needs basic airway management, right? Someone who cannot properly oxygenate and ventilate themselves, correct? Are they unresponsive? They don't have to be. They don't have to be, right? They could have a restrictive airway disease, correct? They could have inhaled something. They could be an overdose patient, right? They don't have to be completely unresponsive, right? There'll be these people who are tired, that's been breathing hard and using all their accessory muscles for hours. You'd be surprised how much of this right here helps. Why? Because you're going to breathe a little bit for them. You're just assisting them. Okay? That goes a long way. So the needs, who, when, how much, what devices, what do you need, right? That's a big one. And you're going to learn this through what? Your assessments and your patient needs, the patient presentations. So I implore you to pay attention to your assessments and your reassessments. We also learned what the devices were, how to place them, the indications, the contraindications, right? When to use them, how to use them, how to measure them. So hopefully now, if you didn't know, you do know now how to measure and how to place these adjuncts. When to suction, when it's okay to roll that patient over, help them get that emesis out of their airway, right? The bag valve mask, right? The easiest, simplest device to use. Are we using it correctly? Are we flowing the right amount of oxygen to it? Are we doing it as we should? Are we helping that patient? The nasal cannula, the non-rebreather mask. We know how to use them. We know what to set them at because we've covered all the flow rates, how to put them on, how to take them off, right? People forget the simplest things, and I don't judge a soul because there's sometimes I forget a lot of things too. I think it comes with age. So the airway adjuncts, the OPAs, the MPPAs, when you use them, the contraindications are important with those, right? Excuse me. Measurement and placement, the suction, right? Suction is an important tool. If you're going to do airway management, the suction should be beside you. I don't care if it's a BLS airway management or an ALS airway management. I can't stress that enough. Suction needs to be right beside you at all times. Because if you have an airway problem, you need to have all of your equipment there, not trying to run to get it, because it doesn't take but a couple seconds. And if they vomit and they take a breath, it's going right back down, right? So you're going to be fighting this battle from the beginning to the end. Patient position, again, some patients will want to sit up more. That's great, right? If the patient wants to sit up, let them sit up. If they're maintaining SATs, if you're able to maintain SATs with a nasal cannula, a non-rebreather, or a BVM, with or without an adjunct, with or without a biad, that's the goal. That's the goal. We want them to be able to maintain those SATs. Everybody said ventilation, oxygenation, right? Ventilation, you're moving the air. Oxygenation, we have the gas exchange at a capillary level, which is what we want. You can ventilate all day long, but are you oxygenating as well? That is a big one. And you may do all that you can do, and you still may not be doing that. But that's a whole different lecture for a whole different topic. So we won't dive into that. But again, I hope I've answered some questions about basic airway management and the needs, the whys, the hows. To me, this is the most important skill a person can have is the assessment and the airway management. Yeah, it's great to have the IV start skills. It's great to have the tube placement skills, but none of that matters if you can't do an assessment. You don't know what the patient needs. None of that matters if you don't have that golden airway. I can give you all the medication in the world through a vein. I can compress your chest. I can splint injury. I can do whatever. But if I don't have this, that's why it's the ABCs, you know, airway, breathing, circulation. Without that airway, you really have nothing. So basic airway management is paramount. And once you've established that, and you've got your patient sats up either through a mask or a nasal cannula or a BVM, and you're using an adjunct, it's important to continually reassess. The patient that didn't have a gag reflex when you started may have one now. So that's gotta come out, right? Most conscious alert patients don't tolerate the NPAs well. They'll pull them out themselves. So most of your overdoses will wake up and they'll grab it and sling it out. It's uncomfortable at best. So, but you're not going to know how that patient is unless you continue to reassess. You want to listen to those lung sounds, right? You want to know what's going on. Let's look at the O2 side. Has it improved? Has it gone down? Are we oxygenating as well as ventilating? What are we doing, right? So again, I hope all your objectives were met as far as the who, the why, the how, and the importance behind basic airway management. And you have at least a better understanding of the adjuncts, when to use them, how to measure them correctly, proper use and placement of a BVM. Like I said, I probably hurt some people's feelings because the best way to do this is with two people. One holds the mask, they can pull that airway open, while the other one just squeezes the bag. If you've ever spent any time in an OR, the first thing they'll do is smack your hand if you go in there like this. They're going to tell you absolutely not. They want you to grab and pull that airway into the mask, right? And just enough to get the chest to rise and fall. That's all we're looking for, right? There's no need to overventilate. Causes barotrauma. We're trying to avoid. Remember that premise: do no harm. So, if you got any questions, comments, concerns, this is our airway mannequin. Again, I apologize I couldn't get a trumpet in there, but if you've seen his nares, you'd understand why. There's like some hard plastic things in there. It's almost like they're blocking us. Not really sure why on that endeavor. But anyway, that's how it is. So I think I wrote down all my objectives, and I hope I've covered them all. I hope I've answered a lot of questions. Just some key takeaways. Gag, no. Gag, yes. Okay. Suction is what? Very important. Simple, the easiest tool that we have. Non-rebreathers, when and how to use them. Drop my cannula, our nasal cannula, when and how, right? And with that, I hope I've answered them all. Looking around, make sure I haven't missed anything. There's our biad, our nasal cannula. So, it doesn't take much to do basic airway management. It just takes practice. If you're a DMT basic, or an advanced, or paramedic, if you're a medical responder, all of this will fall under an EMR scope. There's nothing here that's advanced. Everything here is basic. So basic airway management is part of basic life support. Everything from just having shortness of breath and chest pain to loss of, they're just completely apneic. Everything falls into play as BLS airway management. It's basic. Let's not forget it. Let's go back to the basics. Again, my name's Kevin. If Any questions, comments, please feel free to reach out to me. Again, I apologize for not being able to put the MPA in the mannequin. Maybe we need to get some better mannequins. That being said, thank you for your time. I hope you have a good day.